Hey guys, in today's video we will be discussing about initial assessment in case of trauma patient. Initial assessment in a trauma patient consists of systematic approach, management and resuscitation to know the extent of injury in case of trauma patient to any of the vital organ. Now studies have shown that by doing the systematic approach, the death rate have been reduced by 25 to 33%. Now, first, in case of trauma, the first peak of death is within few seconds to minutes following trauma, and these injuries are mainly because of injury to the brain, brainstem, spinal cord, or to the major vessels, aorta, heart, etc. Secondly, the golden hour, which is the first few hours, mainly the first hour following trauma, is very important in case of trauma patient because by doing our systematic approach, resuscitation and management, we can significantly reduce the death of the patient and improve overall survival of the patient. Now we will go to our main topic. So guys, now we will see the difference between multiple casualty and mass casualty. So what happened in multiple casualty, that the number of patient and severity of injury do not exceed the ability of facility to provide care. So the number of patient and severity of the injury is not exceeding the ability of the facility to provide care, whereas in mass casualty the number of patients are much more than the ability of facility to provide care. So this is the basic definition you have to remember. Now for mass casualty, it is very important to sort out the patient depending upon the needs and availability of the sources, so that a particular treatment can be given to a particular patient, and this is known as triage. So in triage is sorting out patient depending upon the availability and the treatment need of patient. So it is divided in 5 zones. First one is the red zone, which is immediate treatment. So these are the patient in which immediate treatment has to be done to manage any life-threatening emergencies like airway maintenance, airway management and control of bleeding. Okay. Now in yellow group of the patient, we need to give treatment, but it can be a little bit delayed. So it is delayed treatment like management of mandibular fracture. Whereas in green zone there is minimal treatment that is required. Okay, like facial laceration, etc. Okay. Whereas white group is the patient that don't require any treatment. They are mobile, ambulatory patient. Okay, ambulatory. And what are black? Black are morbid patient or deceased patient. So the chances of survival are very less. So they are managed last. Okay, so they are this is the grouping of the patient in various zones according to their requirement. Now after grouping of the patient, triage of the patient, we will do assessment of the patient. Assessment of the patient consists of 5 steps. First is preparation and transport to the hospital, tertiary care, secondary care, where we have to transport the patient. Then we will do primary survey and resuscitation. In primary survey, this all our ABCD will come, and this we will discuss in today's video. Third is secondary survey, which include all CT scan, angiography, FAST, all these things will come under secondary survey. Next is re-evaluating the patient based on all our findings. And fifth and last is our definitive management, which can be delayed, and whenever the patient is stable, we will do definitive management. Now coming to our main topic, that is primary survey. Primary survey is divided or categorized as A, B, C, D, E. So today we are only studying about A. Rest we will B, C, D we will discuss in our later videos. So first looking at A. What is A? Airway management. Airway management. And C, spine control. What is C, spine? Cervical spine control. Okay, so for assessing airway we have to do look, listen and feel. What we will look for? Any agitated appearance of the patient, pattern of breathing, use of any accessory muscles for respiration. What we will listen for? Any sounds like snoring, noisy breathing, hoarseness in voice. These all we will listen for. Then we have to feel. What we will feel for? Midline position of trachea. If there is presence of any foreign object like fractured teeth, there can be dentures in patient mouth. So all these you have to assess the patient. Now we have assessed the patient and we know the patient cannot maintain his or her airway. Then we will move for artificial or advanced airway. So what will come under artificial or advanced airway? So any device that is required to create an obstructed passage, create an unobstructed passage for air to reach our lungs in either in spontaneously ventilated patient or in mechanical ventilation. So this is our definition of artificial or advanced airway. So after knowing what is an artificial or advanced airway, means we are putting any device to the patient to create so that air can pass in an unobstructed way to the lungs of the patient. Either the patient is spontaneously breathing and it's obstructed because of the pooling of blood in his mouth due to any fracture of the mandible or tongue positioning, or if the patient is mechanically ventilated, then we will go for artificial or advanced airway. So first we will start with simple thing. So first is simple maneuvers to open the airway. In this, first comes head tilt and chin lift maneuver. So what happens in head tilt and chin lift maneuver is we apply a backward pressure. This is applying a backward pressure on the head and chin is lifted upward. This chin of the patient is moved upwards. Backward pressure in head and chin is lifted upwards. This is contraindicated where in cases of facial trauma. You have to remember this. You can't do this head tilt and chin lift in facial trauma patients because there is risk of C-spine, cervical spine injury in these patients unless it is ruled out. Okay. Second maneuver is jaw lift and jaw thrust or forward positioning of the jaw. In this, see the head is positioned in a neutral. Head is in neutral position and it is stabilized by both the hands, and fingers are placed on the angle of mandible, and the thumb is pushing the mandible up in an upward direction. So what it will do? It will release the it will also lead to upward movement of the tongue, so that the tongue fall back, or when the tongue is it's obstructing the posterior airway space, it is this obstruction is released. So both these maneuvers we have to do to create an unobstructed pathway for the air. But still, what happens in cases by still doing all these maneuvers, we are not able to open the airway? Then we have to use airway adjuncts. So what are simple airway adjuncts? So first we will talk about oral airway, and then we will talk about nasal airway. So oral airway, this is the most commonly one we are using in our trauma setting. It is also known as Udell's airway. Okay. It has following 4 parts: body, this is a tip, flange, and this is a bite block. And what is it made of? Rigid plastic. And how do we choose the size of this oropharyngeal airway? We will measure from the corner of mouth to the angle of mandible. This distance we will measure, and this is the size of our oropharyngeal airway. Now, how do we insert this oropharyngeal airway? It is inserted in an upside down position. So this tip of this oropharyngeal airway, it is pointing, while inserting, it is pointing toward the palate. So when it is half inserted, like this much it is inserted, we will rotate to 180 degree. So what it will do, it will move the tongue away from the posterior pharyngeal space. So the airway is released and airway is cleared, and there is unobstructed pathway of the air to the lungs. Now we will study about nasopharyngeal airway. See, the contraindication of this oropharyngeal airway is that we can't use in conscious patient because of the gag reflex. Patient won't tolerate this oropharyngeal airway. But in trauma patient, where the patient is not lost his full consciousness, but the airway is obstructed because of blood in the oral cavity or fracture, something like that. So we can use this nasopharyngeal airway. So it requires preparation to how we will do prepare the nasal cavity by using local anesthesia and nasal decongestant. So what we will use? Lignocaine jelly plus nasal decongestant, water, oxymetazoline or xylometazoline. So what will it do? It will shrink the nasal mucosa, and we can insert from the nose to the pharynx. Okay. And how we determine the size of this nasopharyngeal airway? From nose or nostril to the earlobe. And what it is made of? It is made of silicone material. Okay, so this is an MCQ question, and this is also an MCQ question. Now it is indicated when the gag reflex is intact, but it is also contraindicated if there is any naso-orbital ethmoidal fracture, any Leaford fracture type 2 or type 3. It is indicated where the chance of that nasal bone is fractured. Then we won't use this. Or if there is isolated ethmoid bone fracture. Okay. Now we will study about advanced airway. So what happened in advanced airway? If we are not able to manage the airway with all these simple maneuver or airway things, then we have to use advanced airway. So suppose this is our trachea. This is right bronchus, left bronchus, and alveoli, glottis. So advanced airway are classified into two types, and this is our glottic opening. So any airway device that is placed above the glottis, if we are placing above the glottis, then it is supraglottic airway device. Example of this is LMA, laryngeal mask airway. Secondly, if any device if you are placing below the glottis, then it is infraglottic device. Example, endotracheal tube. Okay. Now this endotracheal tube can be of two types, cuffed or uncuffed. Okay. It can be either oropharyngeal or nasopharyngeal. Two types of tube. Then again, intubation can be orotracheal or nasotracheal. These are two types of intubation we can do with this. And third type is RSI. What is RSI? This is again an MCQ question which we will do in emergency situation. This is rapid sequence intubation. Okay. So for intubation we need laryngoscope. So what are laryngoscope? It consists of a blade and a handle. This is the blade part of the laryngoscope and this is the handle. Okay, so these curved blades are known as Macintosh blade. Now, how we will hold the laryngoscope? We will hold with our left hand and will insert from the right corner of the mouth, pushing the tongue and lifting the tongue. So along with that, valvula will also lift and we can easily see the glottic opening. Okay, so this is the function of laryngoscope in brief. Now we will discuss about some special tubes. First one is flexometallic tube. This is most commonly used in head and neck surgery, dental surgery, and neurosurgery. Okay, how it's important? Because it is highly malleable and it is kink resistant. And this feature is important in head and neck surgery because there is lot of movement of the oral cavity, neck. So we need a tube that is kink resistant to prevent inadvertent extubation of the patient while surgery. So it's important to have this feature. And one important question, it is also known as armor tube or reinforced tube. Okay, this is important question. Now, other things that we will second is RAE tube. What is RAE tube? Ring Alvin tube. Two types, South Pole and North Pole. Used in palate surgery. We can easily see this palate because of its direction away from the tube direction away from the palate. Third is uncuffed tubes. Mainly useful in pediatric patients. Because they are used in this patient, because pediatric airways very amenable for injury because of this the balloon that is inflating cuff. So we have to prevent this supraglottic injury. We will use uncuffed tubes in pediatric patients. Now what will happen if we have tried all these maneuvers, all these airways, still we can't manage the air with the patient, or it's very complicated, then or it is a difficult airway, then we have to go for a surgical airway. Surgical airway is of two types. We can do cricothyrotomy or tracheostomy. So in cricothyrotomy, what we'll do, the opening is made in cricothyroid membrane, and in tracheostomy we will directly enter into the trachea. Okay, so we will learn basically little bit about anatomy of upper airway system. So this is our thyroid cartilage, and this is our cricoid cartilage. So what it is? Cricothyroid membrane. Okay, this is our cricothyroid. So where we will do cricothyrotomy? Here. The entry is made in this cricothyroid membrane either needle cricothyroidectomy or surgical cricothyroidectomy, where we will use 11 number BP blade. Okay, now, and this is our trachea, first, second, third tracheal ring. So tracheostomy is most commonly done in second to third tracheal ring, in between the second to third tracheal ring. So if a question is asked, then you have to mark between 2 to 3 tracheal ring, or if other options are like third, fourth ring, then you have to prefer in among these 2 to 3 rings. Okay, second and third ring. Now skin incision can be vertical or horizontal. Vertical incision, it's given in emergency situation, and horizontal when we are doing elective. Okay, this you have to remember. And flap is jaw flap, which can be either T, U, N shape. So this is that's all for emergency surgical area. Now, what are different intubation technique in different surgeries? So suppose if there is nasal bone fracture, or there is naso-orbito-ethmoid fracture, or if there is Lee-Fort 2-3 fracture or panfacial fracture, where you can't do nasotracheal or oropharyngeal airway because either the oral cavity is closed because of IMF, or nasal bone is fractured, there's chance to enter into the middle cranial fossa if we go through a nasal approach. So we won't use our conventional technique. So what we'll do, the intubation of choice is retromolar intubation, submental intubation, or either tracheostomy. But this is least indicated. First you have to mark retromolar or submental. Then in cases where the surgery is very prolonged, then we have to use cuffed tubes more than uncuffed tubes. Okay. Third, if the patient is having TMJ ankylosis, he cannot open his mouth, or oral submucous fibrosis, then what we'll do? Conventionally, when the anesthesia was not so much progressed, or they don't have fiber optic, then they were using blind nasal intubation. But this is not practiced nowadays. Nowadays, we use fiber optics. Either if awake is given an option, then the choice is always awake fiber optic intubation. Last, if it is very difficult airway, if it also doesn't work, then we can go for tracheostomy, but it is not preferred because post-operative care is very difficult for tracheostomized patient. Last is retrograde intubation. For this, very trained anesthetist is required for doing this retrograde. They enter from trachea to the nasopharynx. It's very difficult. So now last is cervical spine management. Whenever any patient with facial trauma, or he or she is having any injury above the level of clavicle, then we have to suspect cervical spine injury, and immediately we have to apply cervical collar, Philadelphia collar, either soft or hard. Use of sandbags, boards, and while shifting we have to use log roll technique for or shifting the patient to avoid any damage to the spinal cord or vertebral column while examining the patient. Okay, so these are all steps regarding management of airway and cervical spine control. So guys, that's all for today's video, and all the points that I've covered in this video are important MCQ question, and the whole topic is important as a long or short answer form. So other parts B, C, D we will discuss in other video, and all related MCQ in this topic. So guys, I hope this video is informative for you in some way or the other, and stay tuned, like, share and subscribe my channel, and let me know in comment section what all topics you want me to make videos on. Thank you. Bye bye.